Perfect. So good evening, everybody. So today we are going to do a very basic stuff. As discussed, this is about the stuff that we need to learn, which always we sort of leave it behind. Like for example, how do we pace and how we set everything and all that stuff. So the stress in this class would be on the pacemaker. Towards the end, we'll discuss a little bit about the AEDs. All of you must have used an AED by now, and also about in which areas how do you react a little bit, especially a broad line. Okay, that's it. Now, because the pacemaker stuff is so big, I have to go a little bit brief on the later aspect. But if suppose after this lecture, as I always say, you feel that we need to have a bigger class on arrhythmias related to post-operative and pre-op issues, then in that case, we'll have to keep a separate session for that. Also, there's one more request to take a class on hemodynamic monitoring, which I think I should be taking by next month or the month after that, if everything goes well, because month I have a busy schedule. Okay, so let's start now. Okay, so as you know, pacing after pediatric cardiac surgery. When do we require pacing after cardiac surgery? Either it would be a conduction abnormality, simply put as an AV dissociation, in different forms, where you do not have a one-to-one conduction of the atrial to the ventricle component, and there's a prolonged AV delay. AV sequential pacing we do in that situation. Similarly, if there is a prolonged QT syndrome with significant tachycardia, which is rarely seen sometimes in the pre-op situation, you may have to use a pacing thing. And again, in a slow junctional rhythm, sometimes to restore AV synchrony, you have to use pacing. Okay. Now this is the temporary pacing. Today, mostly the talk will be about temporary pacing, because permanent pacemaker, once it's done, all the settings and everything are done by the electrophysiologist, but the principles are more or less the same. So please remember, the principles do not change. So whatever we are doing in temporary pacing, permanent pacing has a little bit more benefits because there's some inbuilt mechanisms which are there because of where it is. But the principles of pacing, which is like output, sensing, all that stuff, is more or less the same. Okay. So just give me a minute. Just give me a minute. A lot of tachycardias that we face, either supraventricular or atrial tachycardia, where sometimes you have to use pacing to bypass the junctional rhythm, or sometimes a rapid atrial pacing to terminate the reentrant SVT. Okay. So you need to understand that pacing has also got benefits, like for example, in fast rates by going super fast at rapid atrial pacing, and you can sort of terminate the abnormal rhythm, especially the reentrant rhythms. Prophylactically, sometimes it is used for post-operative, especially when you have a VT and you're shocked and some bradycardia, you may have to do VI pacing transiently. Similarly, in atrial fibrillation, biatrial pacing sometimes works. Now that is something which is still not reached us, but yeah, there is a concept of biatrial pacing. Bipolar pacing after valve surgery, so that is something which does happen, and in a lot of centers, probably abroad, they're doing it as well. Okay, or with in a CHF patient, they come into biventricular pacing for a permanent pacemaker as well. In the hypertrophic cardiomyopathy, especially for a very specific reason of reducing the systolic anterior mitral motion of the anterior mitral leaflet. Now that is a very rare indication, I'll be very frank with you. And heart transplantation, sometimes if you result into heart block, you may have to use it. Now, you all seen the pacing wires, two wires which are kept on the right side, two wires which are kept on the left side. They are referred to as epicardial wires. Now, the epicardial wires are put during surgery, but as any foreign body, they can have an infection, they can lead to myocardial damage, they can lead to destruction of coronary anastomosis. In case they migrate, they can create a tamponade. They are also sometimes result in sinus after removal of the wires. Now, why usually placed on the right ventricle and on the right atrium? If seen the pacing, I hope all of you have seen it. There is a small needle end which anchors to the myocardium, and large needle end is brought to the skin surface and connected to the Medtronic cables, which you see in blue and white colors. Most centers are Medtronic. A few places would be having Siemens, which has got a different way of connecting. But I have to concentrate on the Medtronic pacemaker, which, if you can see, is here. This is the pacemaker, dual chamber, temporary pacemaker. This is what we use in our practice. This is something which you'll be using in most of the places. So we'll discuss the things on this graph. Siemens is there, But at the same point of time, Siemens ventilator, Siemens pacemaker, for example, it is a little bit not as user friendly as what we have. So in an emergency, you can use it, but then it has its own problems. But the principle again in that also are the same. So biventricular pacing wires are indicated to the left ventricular myocardium as well. This is for your information. Now, at least in India, as of now, we're not doing biventricular pacing, but it is definitely doable. If suppose you require for a specific scenario, you can do biventricular pacing. There's no big deal about it. So basically, you have one set of wires on the right ventricle, which takes care of the right ventricle, one set of wire on the left ventricle, and so on and so forth. So you require two pacemakers specifically for that. Okay. Now, ventricle is predominantly put at the right ventricular outflow tract, and in the atrium, it is put in the right atrial appendage. This is for your information. Okay. I don't think so anybody is going to ask you specifically about this, but this you should be aware where it is there in the time when people used to put a single pacemaker wire, which was called a unipolar thing. Now, single, which obviously goes to the epicardium, and then in that case, you used to use a positive in the skin or subcutaneous tissue. You need to complete the circuit. Otherwise, current will circulate in the body only. It has to come out. So, there has to be a positive in the skin or subcutaneous if you don't have a bipolar connectivity. The alternative bipolar system, when you have two wires on both the sides, so you have single with two conductors insulated from another, which both run to the epicardial surface, and the negative anode is usually a distal one. Now, this negative one, when you come out, you put it in a negative marked cable. Cable, you'll see there's a mark of negative, there's a mark of positive, so you have to put it in a negative mark. Okay. The minimum distance between the two when you're putting a bipolar system is around 8 millimeter. This you should be aware. Now, this is important because in bipolars, the current travels a shorter distance. The electric potential required to bring the myocardium to threshold is lesser. So I'll tell you later why it is important, because the more the electric potential you give, the more chances of inflammation around the wire, the more chances of failure to capture after some time. So hence, we have to be very cautious that if suppose you're doing a bipolar, it's always safer because it helps you in maintaining or sustaining temporary pacing for a long time. Now, chances of interchamber interference obviously is reduced. There's better sensing as there is less electrical interference due to short distance. So you would have seen in practice, when you put a skin wire, single wire, sometimes it will pace, sometimes it will not pace. You have the output which is very high. All those things you can cut down, and hence most of the good centers definitely use two wires. A few place people are a bit more confident, they will put just one wire and come out with it, which sometimes backfires also, if I may tell you very frankly. I feel that you should be having, especially in any open heart surgery, two good atrial wires and two ventricular wires. It's always safer. This current creates larger spikes in the unipolar mode, which obviously now we've put. Now this is something which you should remember. And suppose you come out with a single kit, you'll remember this. What I'm saying, a larger current is given, so that will lead to more spike on the ECG, whereas the spike of this will be actually very very small, especially bipolar. So are always on the right side, except for in the case of situs inversus or situs ambiguous, with the also affected where the right atrium is on the left side. Then in that case, you have the atrial wires on the left side. So whenever the patient come out of the OT in a patient with heterotaxy syndromes or situs inversus or situs ambiguous syndrome, you should always ask the surgeon where has he put the atrial wires. Ventricular wires are usually on the left side. In the similar scenario, they could be on the right, especially with heterotaxy. Now, color code of the wire is done in a few centers, but here most of the people color code the. So the white cable goes to the ventricle, the blue cable goes to the atria. But don't fix yourself on that. You leave your wires. Don't be worried about them. If you label your wires properly, that it is atrial, this is ventricular, you will be more safe. And then remember that and put whenever your cable is put a sticker on. This is atrial, this is ventricular. There is no confusion. Now, this is a foreign body which is there in the heart. There will be inflammation around it, and hence there is an accelerated inflammation via epicardial waves if higher potential used. More the current, more the damage. Hence, you should try to avoid very high potential. So that's a two-way thing. If the surgeon has put the wires properly, automatically the things will work. If the wires are not in the proper place, you will have to give a high potential. So it works, which is not under your control. But when things are working at a lower potential, don't go high just for the heck of it. That's important. And biowires, because they require lesser potential, have a greater longevity. Now, wires, because of the temporary nature of the entire thing and because of the inflammation, they fail to capture our sense after a few days, and have an increase in stimulation threshold typically after 4 days in both atrial and ventricular wires, and failure to pacing is observed in 60% of right and 80% of left, especially when you have the two wires separately put on the atrium. Controlling the threshold, variation in placement site balanced against human. So obviously, now as I said, you have to keep the output list. Make sure that the placement site is at the right place. Make sure that hemodynamic optimization is done at the right time and your things get better. Sometimes a few people recommend use of steroids, but to be very frank with you, we use steroids till date to increase the longevity of pacing wires. But yeah, theoretically speaking, and so recommended as part of the reviews that have been done abroad, that high dose systemic steroids are sometimes given to candidates with rapidly increasing thresholds. Steroid eluting wires have also come into place for the PPI. Top players are pacing are used for your atrial ECG recordings, which is the pacing wires, and I'm very sure that all of you would have done those ECG recordings in your place, especially to differentiate between a junctional tachycardia and a sinus tachycardia when the P wave is not very clear. I'm sorry. So atrial electrocardiogram is the best way to differentiate that. So there are recorders which unfortunately we don't have, which have a lead specifically for the atrial wires and for the skin electrode. So you have to do two for the bipolar atrial wires, one for the skin electrode, and AEG channel is set to lead one in that, and so on. But if you don't have that, no hassle. Even with your existing electronic ECG recorders, you can still do the bipolar atrial wire recording, wherein in the easily for the right arm, the you have put up the right one wire of the atria. In the left arm, you put another atria wire, and gives the usual electrode, and see the ECG. So when you see the ECG, you will say that if depolarization happening in the atria, it will be recorded with the spike. Now the spike is between if it's set to lead 2 or lead 1, for example, as I just mentioned. Sorry, the tip is asked if it's set to lead 1, the potential between the tips of the two atrias is recorded as large deflection with atrial polarization only. This is important to remember, and then you will see the depolarization after that. And if set to lead 2 or 3, the potential between the bipolar and skin electrode is recorded. Large ventricular signal is recorded. Okay, so I'll just show that to you as an illustration. Most you can diagnose in patients where the P waves are dropped in between your second degree AV block, when isorhythmic dissociation, they can be easily diagnosed. Now, it allows recording of timing of sinus depolarization, as I just mentioned, opposed to P wave activity, and also the identification of sinus or other atrial activity that might otherwise be lost within an ectopic depolarization. So, very important tool to differentiate junctional tachycardia, because the treatment of junctional tachycardia is different from sinus tachycardia, which JET is something which you encounter so commonly. If you look at this atrial ECG, so you can lead, this is the lead 2. The lead 2, you can see that this is the spike, which is followed by the wave which is coming in, which is the depolarization, and lead 3, which is this again the between the one of the electrodes and the link electrode. This will be a prominent ventricular complex. Okay, so this is what atrial ECG looks like. In cases where you are not sure whether the P wave is there or not there, it will always help you. Regular pacing modes that you have a mode for transvenous pacing, you have an esophageal probe electrode pacing, you have a transvenous electrode pacing, which is in a dead emergency, and in a trans which can be done, especially in if the patient is not having the wires or the wires are not functioning, where the G tip is placed in the right atrial appendage, and is one balanced with the wire which is spread to the skin, and so you are managing at least a unipolar sort of a pacing in that, in diastole ventricular pacing. Okay, it's only for dire situations. Now, Pacemaker wires, they're being sort of something can conduct electricity. You have to be careful about how you to be using. They are loose-end wires. They can create microshock environment and induce ventricular arrhythmias. So you should be nursed in a cardio-protected electric environment. Avoid static electricity. So obviously, our ICUs don't contain carpets and everything which contains the static electricity. So you should be avoiding that. Wires should be touched with a non-conductive glove while being in contact with the metal stuff to have static potential before touching the wires. And it should be kept protected in a plastic or similar non-conductive environment. So either it should be a needle cap or a cinch cap. You can do that. Okay. When somebody is on a pacemaker, it involves underlying rhythm. when you're doing the underlying rhythm, decrease the rate rather than output, because if you decrease the output and the failure phase to capture, sometimes the recapture will never happen and your patient will crash. See, now to the other things, which is sensitivity. Now, sensitivity is the thing which we see out here. If I the pacemaker, the lower. Now, the sensitivity, the better it is. That means the pacing wire is in the proper position. Okay. Normally, the sensitivity is set at half the pacing threshold, not beside the pacing threshold. Now, if I show you this thing, as you can see, I'm just this is an AI mode which is going on, and I just increase the sensitivity. Now, it is not connected, so it will not show that, but there will be a point where the patient go into an asynchronous sort of a pacing. If suppose that has happened, for example, at 8, you should keep sensitivity at 4. So it will get half of that. If no endogenous rate at, so this pacing sensitivity threshold, where the pacing increase the sensitivity. Now, when we say increase the sensitivity, it's a paradox. The lower the value of sensitivity out here, the better the sensing is there. The higher the value, that means it's poor sensing. Okay, that's it to remember. The higher the value out here, that means the ventricle is the wire not in a proper place and it is not a very good sensing wire. But and hence you have to go up on the sensing to that level. Okay, to make it towards asynchronous, in fact. So remember to see this. This is the lower panel where you set the sensitivity. I have to go to the when the patient is like stable after spacing. How to hide the threshold? You go up on the sensitivity and place where it changes from sensing to pacing. That invariably, even if though there is an inherent beat, that pacing threshold, and you come at half of that. If there's no endogenous rate, then you keep it at 2 millimeters. A very low sensitivity, as it may sense a far field signals such as R and T waves, which may inhibit pacing inappropriately. Threshold, and there's the capture threshold. Now, capture is basically done like when you are doing the pacing, seeing that the ECG there is a pacing spike, and it is followed by contraction. Okay. No. Capture threshold. If you look at this, it is set out here as an output. Now, threshold is the minimum pacemaker output to stimulate an action potential in the myocardium. This should be checked if there's no underlying rhythm, as sometimes we lose again, and you should not be taking that risk. So you should always be very careful at what is the underlying rhythm. If your doesn't have any injection by itself, in case never do these experiments of going up and down on the capture and sensitivity. Wherever it's working, leave it. Only when it has some sort of activity, it's better to check it. It will be safer. If the beats are there, no. If then when you're pacing, but occasionally the patient is not capturing, you may have to go up on the output. Now, if the patient capture threshold, the pacing rate is set above the patient's endogenous rate, so that to make sure that there is consistent pacing, then this output is reduced. See, I have to unlock and I have to reduce this output. So we are checking the pacing capture, the lowest potential or the lowest output at which the pacing will happen. So for that, if I've kept it at 10, I reduce it. Now, just an illustration is suppose, for example, at 3, it's pacing. In that case, I have to keep the output at least 2 times, that is at 6. If I kept it at 6. Okay, this is important. Okay, so you need to remember this has to be also calves. You should be knowing. So output, if the pacing wires are kept for a long time, may increase. So hence, it is important to see whether the pacing that you're doing that is being captured or not, and then is resulting in improved output. So if the pacing threshold is very high, you have to obviously can't keep the 20. You have to keep it over value, because the more pace that you keep out here, the more the chance of accelerated fibrosis. So if the wire is spread properly, normally your threshold should be matching around 5 or 7, and you should be able to manage. Cardiac output is the sum of heart, if it is a function of heart rate and stroke volume, and optimal heart rate is based on the age of the patient. So avoid it for long duration as it increases the oxygen consumption. Obviously, you all understand that too much tachycardia, even pacemaker induces is not good. As a transition to complete trance or endogenous rhythm, a brief duration of backup pacing should be tried if possible under observation without allowing hemodynamic compromise. Where there is an inherent rhythm. Remember, where there is an inherent rhythm, you cannot be checking a patient who's flat trace and then say 5 minutes, the patient sometimes will not come back. So please don't do that. Where you know there's a rhythm, then only you can do all these transitions. Like you reduce the rate and see whether the patient is capturing or not capturing and all that stuff, and whether these have evolving into a own rhythm. Okay, so remember that. Now, also, you have to have a situation where doing this stuff, at the same point of time, you allow sensing threshold to be continuously monitored. Because if suppose the sensing is not proper, then you won't be able to detect the endogenous rhythm properly. So it's important to keep a check on the sensing part as well. So I hope everybody has understood the pacing sensitivity threshold and pacing capture threshold. Then we move ahead. What is the NBG code for pacing? So the first letter is the chamber paced. It can be atrial, ventricle, or dual. The second letter is the chamber sensed, which can be again O depending on a asynchronous, atrial, ventricle, dual, and response sensing. It's asynchronous, which is O. I is inhibition, T is triggered. D is equal to trigger inhibition, and that both the functions are there. And why it is important, we'll come to that later. Thing about all the pacing, so I just show you on this. If suppose we have atrial asynchronous, so asynchronous means the sensitivity should not be there. So go up on the sensitivity to see. So you see out here, this is asynchronous. This is AOO out here. You look at it, that's important. So for asynchronous, you have to go to asynchronous mode and you have to increase the sensitivity and go to async and increase in this direction. So the patient's beat is not sensed. Important. Patient's beat is not sensed. It is specifically within bradycardia with intact AV node conduction in situations where synchronous modes are contraindicated. For example, in electrocautery, just to make sure the current doesn't disperse or doesn't generate abnormal rhythms. Patients, it is contraindicated in atrial tachycardia because it can actually lead to a sort of a fast ventricular rate, and sometimes fibrillation. It can also precipitate a fibrillation. So, if you are in the OT where using, or you are in an electrical field which is strong, or a pacing is not happening properly because the output required is very high, and you are not able to capture properly in that field, you may go to asynchronous. But when you go to asynchronous, please make sure that you are coming back to that and checking to the patient whenever the patient is out of that electrocautery time or whether the patient is stable. Just see whether you can come back to a sensing mode, because sensing will always help you, because that will allow the recovery of the endogenous rhythm. Asynchronous. I'll show you on this. Now, for ventricular asynchronous, I have to make the atrial output 0, which I make out here. Okay, and increase the ventricular output. Obvious correspondence to this, you will see the ventricular sensitivity out here downstairs, and increase it and go to asynchronous. This is EOO, as you can see out here. Now, EOO is used in an emergency where you have bradycardia without reliable AV nodal conduction, and rapid assist function in emergency to assist cardiac output, just have some ejection. And inhibition, it competes with intrinsic rhythm, because if you are putting an asynchronous, it won't allow the endogenous rhythm to be seen. Sometimes ROT phenomenon can happen, which can lead to VF, which is always a risk. So asynchronous is a temporary thing. Asynchronous is something that you need to ensure that the pacing happens in an emergency, but it is a temporary phenomenon. The more patient is stable, electrolytes, temperature, everything is in place, maybe dose is corrected. Maybe you should definitely look into the pacemaker and see whether you can go to the sensing modes. So that's asynchronous. A very long time is not very healthy. AI atrial demand or VVI ventricular demand pacing. Now this means that if the patient's rate is slower, it pays, then the set rate. If the pitch rate is faster than the set rate, then they will not pass. It will only sense. Hence, it is a proper AI, for example, as I just show you. I'll show you VVI since we're already there, so it's not a problem. Okay, so you understand the ventricular sensitivity. The moment I bring it down to, for example, the pacing cap where sensitivity threshold was 5, I've kept it at around 2.5. It will sense. So I'll make the output out here. I'll go up on the output out here. 4, 6 something, and this is AI, as you can see. sensed atrial pace on demand if the patient's own rate is lesser than the set pacemaker rate. The rate is set from here, obviously. That's what you all know. This is the rate point setting. Now, V is very similar to AI, but when there's no reliable AV conduction to the ventricle, if there's no significant AV conduction happening, you may have to use a VI in an emergency situation. All dual chamber pacing is better, but sometimes it will not. Sometimes the atrial wires are not there because the surgeon never presumed that these things were going to happen. So you may have to do a VVI in a dire emergency, especially bradycardia with AV block in 6-sinus syndrome, fibrillation, atrial flutter to control the ventricular rate. Over time, ectopic beats that sometimes can be achieved with VVI as well as AV sequential, or sometimes again with atrial pacing that can happen. But you should remember that when you do a VVI pacing, there's no atrial contribution to ventricular preload. AI, it is done in patients with bradycardia with an endogenous atrial rhythm sufficient to compete with the pacemaker rate. So basically, when you say AI, you remember that it is that if the pace rate, for example, you say the pacemaker rate is 100. If it is below 100, it will pace. If it's above 100, it will not pace. This is AI, inhibitory mode of the pacemaker. Dual modes, definitely physiological, and you use sequential synchronous as mentioned in the OT sometimes. That suppose the patient is AV dissociation in the cautery, everything is still connected. And if you know that the patient will benefit from pacing, especially with the atrial contribution, in that situation, it will always be better than a DO. Now, DO, as I will show you out here. You will unlock. You have to have a ventricle output for that. Output for that, as you can see, it becomes DD. Now, if I reduce the sensitivity out here, atrial gone. It becomes DOO, ventricle gone. Look at this. Okay, both is synchronous. There is a risk of RNT phenomenon because the endogenous rhythm is not sensed, and there can be a situation where it can precipitate the RNT. So, synchronous, remember that it is meant for only temporary duration in the lieu aggravating factors. Okay, now intrinsic depolarization, which is AV sequential ventricle inhibited, it is a TO in sense of any intrinsic depolarization. So here, for example, you have both the endogenous ventricular depolarization is sensed, the ventricle spike is inhibited. So, in the atria which is paced asynchronously, but if the depolarization is sensed, the ventricle spike is inhibited. Sometimes the atrial rate, there can be a risk of fibrillation, especially if the atrial spike is not inhibited in the endogenous atrial rate. Ventricular sensitivity is high, and atrial depolarization might be appropriately assessed as a ventricular activity, and ventricular spike is inhibited, which is referred to as crosstalk. So, if the ventricular sensitivity is high, even atrial depolarization is high, means this value, which is out here, this is kept at a lower level. This is ventricular sensitivity high. Out here. The atrial depolarization might be inappropriate just as ventricular activity and ventricular spike is inhibited. This is referred to as crosstalk, which we'll talk about later. And this is hazardous because you have an atria which is contracting. The ventricle is actually not getting conducted beat, but because the atrial impulse exciting the ventricles, it has got inhibited, and you don't have a ventricular output. So basically, the patient is in. That can happen. Remember that if the ventricular sensitivity is kept very high, atrial depolarization may test as ventricular. So hence you have to be very sure that you don't keep the sensitivity value out here. You keep it on the between after judging the pacing threshold. Keep half of that. Don't keep it very low. 0.5, 0.1, 0.3. That will backfire. Okay. This is absence of AV conduction of endogenous beats. Ventricular beat is conducted retrograde through the AV node. Atrial sensing wire would sense the atrial activity, and in DDA and DDI mode, it will precipitate a release of pacemaker-induced tachycardia. So, basically, about the ventricular pace beat, which is conducted retrograde through AV node, and again, atrial activity in precipitating a pacemaker-induced tachycardia. Now, in DVI mode, this doesn't happen, but predicated for atrial arrhythmias and can also precipitate atrial fibrillation. Be careful. That's really not used up in DVI by the world standards. sequential non-pre-synchronous dual sensing, while DDD is with A. So in DDI, the P wave is not synchronized and the P wave is tracking is not happening. Whereas in DDD, the atrial tracking is happening. Now I'll show you where is this atrial tracking in this pacemaker. If you look at it carefully, you have atrial sensitivity, ventricular sensitivity, AV interval, upper rate, and PVARP. PVARP, which is peak ventricular atrial reflect, post-ventricular atrial refractory period, and there is atrial tracking, which is on. This is there with all of you. You can have a look in this panel, and you'll get the answer when you set it on dual chamber mode with DI, DDI, or DDD. Okay. Now, DDD atrial tracking, the maximum rate is not a set lower rate, but very pacing spikes can be delivered at a higher rate based on atrial tracking activity. In patients with paroxysmal atrial tachycardia is because whatever the essential high fast rate, if it goes beyond a certain thing, that changes from a DDI to DDD, and it is sort of inhibited. In terms of atrial tracking, no increase in pacemaker rate with age-appropriate sinus tachycardia. So if the not happening, there will be no increase in patient rates with age-appropriate sinus tachycardia, especially in the situation where you have DI AV sequential non-synchronous in the tracking. There will be pacemaker rate based on the age-appropriate endogenous rhythm. Okay. So DI is non-synchronous, dual sensing, DDD is atrial tracking, it is p-synchronous. So if patient's heart rate goes faster, it will be reflected in DDD. Okay. If patient heart rate goes slower, in DI, the rate won't be reflecting there. Okay, that's important because it's not synchronized with the P wave of the patient. So it's very important. I'll just repeat that. The DDD with atrial tracking, the maximum rate is not the set lower limit, but ventricular pacing spikes can be at a higher rate based on the atrial tracking. So the patient rate is faster, there will be more ventricular pacing spikes. Okay. So for atrial tracking, no increase in pacemaker rate with age-appropriate sinus tachycardia. DDI is beneficial in patients with paroxysmal atrial tachycardia with prograde thing. So the patient indigenous atrial defibrillation, atrial cycle issues. The waits for the endogenous ventricular defibrillation to respond to the pace spike or endogenous activity and ventricular pacing spike issues. Okay. For all modes of pacing with exception of atrial tachyarrhythmias, remember, atrial tachyarrhythmias, if they are tracked, they will lead to a very fast ventricular rate. DD changes to DDI with Medtronic pulse generators if rapid atrial rate encountered with tracking on. Safety mechanism. Atrial tracking goes off. So there's the same pacing rate at what you're pacing. Okay. So that step further, just P wave synchronous, but here only the ventricle is paced. If you use patients AV node block with intact sinus node, the same as a DDD, atrial tracking, and following a rapid changeover to VDI mode. If suppose a fast atrial rate suddenly that crops up, and you can see your tracking blinking frequently, you will have a space to correct the threshold and also follow a rapid change over the 2AI VDI mode. Basically meant for patients with the problem of oversensing, but asynchronous modes normally give you the answer in patients in the few instances where we see oversensing in the ICU and as well as in the OT. Important. If you have a pacemaker, there can be a failure to pace. Now, why do you have failure to pace? The failure to pace happens because there's no electric. So either there's a problem with the wire tips. This is from failure to capture. So if you see the failure to capture, there will be a pacing spike, but no corresponding output. That is failure to capture. Pacing spike is seen. Patient is less than the minimum rate set on the pacemaker. So that means capture is the patient is not pacing. Okay, because of many factors, it could be because of poor lead. So many factors could be there. It can be a local malfunction or an unstable connection between the lead and the pulse generator, insufficient power to the pulse generator, crosstalk inhibition, over-magnetic interference, which leads to active period for the myocardium and leads to this unbalanced pacing, and detection of endogenous extrasystoles of insufficient amplitude to register on the surface electrode, which inhibits the pacemaker. So there may be an ineffective endogenous extrasystole which registers as a depolarization, inhibiting the pacemaker output, and failure to pace. Asynchronous mode does not change anything in the first two scenarios, which is failure to pacing due to local malfunction or an unstable connection between the lead and the pulse generator. But I totally agree with him that you will have a situation that we need to get it corrected for our sanity and ensure that we are having a proper pacing happening irrespective of those factors. Okay, you know there are certain factors which I'll come to later, which are patient factors. But there's surgical factors if the pacing wire is not put and so on. So if suppose the pacing wire tips are not put properly, it may not pace. So failure to pace is no electrical output at the pacing wire tips, distinguished from failure capture by the absence of pacing spikes in the circuit. In failure to capture, there will be pacing spikes, but won't be seen as a corresponding output. It won't be seen as a contraction after that. So that output ring will be a problem. That's failure to capture. But the pacing spikes will be seen on the monitor. In failure to pace, the pacing spike will not be seen on the monitor. That's important. So device, local malfunction or unstable connection, insufficient power to the pulse generator, crosstalk inhibition, oversensing with electromagnetic interference, and of endogenous extrasystoles. Insufficient to register on the surface electrode, inhibit pacemaker output. Asynchronous mode does not change anything, as I said earlier in the first two, which is in the local bodies, and insufficient power to the pulse generator. Let's discuss with you the entire thing. Failure to capture. Failure to capture is because you have an electrical output at the pacemaker wire with pacing spike visible but does not cause a cardiac contraction. This could be because of the increase in the resistance of the via myocardium interface, most commonly due to fibrosis around the pacemaker lead, which is in the later part of the first week after surgery. Additional factors could be your myocardial ischemia, electrolyte imbalance, hypokalemia, acid alkalosis, following defibrillation, hypothermia, metabolic acidosis. It is a problem, and if you have to reverse it, you have to identify the above causes, which are mentioned out here, which is myocardial ischemia, hypoxia, electrolyte imbalance, hypokalemia, alkalosis, following defibrillation, hypothermia, and metabolic acidosis. In these, you can have a failure to capture, which is happening. So when you have to capture, what do you do? So you have the cable where it connected the polar leads. You have to run to the negative, one to the positive. You change the polarity. Still negative electrode, develop fibrosis first. Use the proximal electrode as a negative electrode and return the electrode inserted into the subcutaneous tissues. That is another way to go about it. Transvenous via, especially if the capture is entirely lost, that will be very unfortunate, but if it happens, you will have to do it. Failing so similarly, a similar way, it is because of the lot of aggravating factors which are there, which are mentioned out here. And in situation also correct the aggravating factors at the same point of time, ensure that your patient is getting paced regularly at the rhythm that's decided. So a phenomenon called crosstalk in relation to the pacemaker earlier, and especially in dual chamber systems, it is the problem. The atrial pacemaker spike is sensed by the ventricular wire, especially if its sensitivity is very low. Okay, and sensitivity low means a very low value out here. Okay, so the patient's ventricular wires are very sensitive. If the sensitivity value is high, they are less sensitive. Atrial, no sensing. So understand, say sensitivity high and lower setting out here. Okay, that's important. And atrial pacemaker spike can lead to a ventricle being misinterpreted as being sensed and misinterpreted ventricular depolarization. And this automatically, as a refractory thing, inhibits the ventricular pacing spike in absence of AV conduction. And this can lead to total ventricular disastrous effect. So always remember that your sensitivity should be adjusted properly, so you don't oversense things. It can also happen where the ventricle, the pacemaker spike can do the atrial stimulation, but that will not be that hemodynamically significant. But atrial leading to crosstalk with ventricles is terribly significant. Monson is a system that allows atrial sensing, crosswires to trigger ventricular pacing spike, resulting in pacemaker-induced basically mediated tachycardia. So, I think crosstalk, ventricle related, you get cardia because the atrial rate sometimes can go very fast, especially in AV dissociation. Okay, I've seen, and we do a async pace. For example, in this situation, we sometimes do an async pace. We keep it at a lower rate if the atrial rate is supposed to be higher. So this will be blue out here. That is async pace. That happens. Okay. In a number pacing only. So, but in sync and the ventricle, then sometimes the async would be faster. There can be a one-to-one conduction with because of the ventricular depolarization being misinterpreted due to the excitement of the ventricle wire, and that can create problems, which is referred to as pacemaker mediated tachycardia. So, resistivity, increase the lowest power that is sensed. So, you have to keep it based on the pacing threshold. Reduce the output to the ventricular atrial pacing wire, and use inherent safety features like ventricle blanking period or ventricle safety pacing, which helps in this situation. Which is that the time from the atrial to ventricle conduction is in the interval for atrial depolarization before the ventricle spike is delivered. The patient's AV node sometimes may be able to conduct an inherent impulse. If the set interval is longer than the time to conduct to the node, the ventricle pacing spike is inhibited. So, okay, whatever AV interval you have set out here. Now, AV interval where you don't set, AV interval is based on the rate. So, if you look at the parameter, the third parameter is AV interval. Yeah. So, it is no touch that. It will be automatically based on the rate, it will get adjusted. So, as possible, avoid touching that. Okay. There will be some people who are interested to do it, but sometimes it doesn't work. If it doesn't work, it doesn't work. You have to understand. So there will be plenty of factors. There could be metabolic factors of the patient, which we mentioned before, hypoxia, hypoglycemia, along with electrolyte imbalance, hypothermia, and can be pacing-related factors, which we are discussing. So remember that A is set automatically. Interval is longer than the time to conduct through the node. The endogenous rhythm would have gone, the ventricle pacing spike is inhibited. But it is shorter, then pacing spike will be delivered. Okay, so that is how the advantage of AV delay. So you have the pacemaker which does the role of an AV node in that situation. Now, pacemakers have the provision of differential AV intervals. So, for example, if suppose you have a patient who has a rate intermittently, the permanent pacemakers will allow AV natural interval hysteresis, and this interval is able to facilitate endogenous conduction. Okay. About delay. So remember, this AV interval hysteresis and everything is part of the permanent pacemakers, where the AV interval automatically is based on the endogenous conduction is malleable. It's automatically readjusted. But that readjusted out here. Can you set it? If it is longer than the time to conduct to the node for the endogenous beat, the ventricle pacing spike is inhibited. If it is shorter, the spike will be delivered. Okay. Sorry. The mediated tachycardia, which we have discussed related to crosstalk, is a potential problem in DD pacing. Atrial sensing of a ventricle pacing spike, which is interpreted as the endogenous atrial depolarization, triggers another cycle, leading to a faster rate. Now, it's overcome by the atrial blanking period, which is an automatic setting. It becomes a retrograde conduction of a ventricular beat. In that case, you can overcome by post-ventricular, and hence PVARP, you can adjust it marginally in such situations, which is there. Again, PVARP, post-ventricular atrial refractory pressure, shows up here. You can see PVARP here in the lower panel. Okay. This is a default value based on the rate, but sometimes you may have to adjust it. But believe me, if you have to adjust it, involve the electrophysiologist. Don't do it by yourself. At that point of time, there's no point, because if you can, with most of the things adjusted, very rarely you have to require a situation where this is interfering with the normal conduction. But if you do make sure the electrophysiologist is standing by your bedside. Okay, this can be disastrous sometimes. Entrant pathways will be terminated only if the mode, as we will say, switch to DVI and DVI. I don't agree with it personally. Entrant pathway can also be, especially with a little bit of overdrive pacing and everything, can be getting better. But pass on a message to sir. I think he's aware that what the other one is coming, so maybe at that point of time you can answer. Okay. So, mediated tachycardia. Remember, far field atrial sensing or ventricular pacing spike is interpreted as endogenous atrial depolarization, generating another ventricular impulse. So, the way has happened, it automatically activates the atria, which is Okay, because T being low and leading to another cycle immediately, and the rate goes very high. So remember, if you are setting to a default value, that will automatically take it. Sometimes you may have to adjust it, involve the electrophysiologist. If re-entrant pathway will be terminated if the switch mode is switched to VVI or DVI, but this may incur the penalty of losing AV synchrony. But situations where it is a crisis, you can go to a VVI mode from a DDD mode and be stopped. What a shot, especially spike is exciting the atrium prematurely. Which is the ability of the pacemaker to bring the myocardium to action potential, which is determined by both the current intensity and duration. Inside. Reducing the pulse duration may reduce the fibrosis and in permanent pacemakers conserve battery life. But it is preset in pacemakers and rarely altered. Something which I showed you in the atrial thing. When you're doing the atrial pacing, you will see, even in this it is seen, upper rate out here. If you can see it, the atrial tracking, that's there. And again, there's an upper rate which is set. So this up rate is the fastest the pacemaker will pace the ventricle in response to a sensed atrial event. So it's an automatic defense. Okay, this is all automatically set by the pacemaker. The atrial rate goes higher and electronic type 1 Venki back is induced. If the endogenous atrial activity goes higher. So this upper rate adjustment is out here, and this automatically, again, you don't have to, but you should be aware about it. Why it is there? That's important. Okay, so that will help you in understanding your pacemaker better. So the atrial rate goes higher, electronic type 2 Venki back block is induced, where gradually increase the interval until it is so long that the next atrial depolarization follows the refractory period of the preceding one. It's ignored, obviously, because the refractory period will be ignored. Okay. If this beat, now this sum of AV interval and PVRP is the total atrial refractory period, and if endogenous beat is separated by less than total atrial refractory period, every second beat is missed. So this is an automatic way of protecting the ventricular rate. So the faster atrial rate doesn't get conducted into a faster ventricular rate. Required to set it in the permanent pacemaker when they set it in such a way that at the rate at which the block results, you set the upper rate limit slightly lesser than that. Low output related to cardiac arrhythmias. Now, this is something which is a cardiac arrhythmia of some form has happened, which could be an AV block, which will do a dual chamber pacing. There could be ventricular tachycardia, ventricular fibrillation. There could be an SVT. There could be a bradycardia, which could be later responding to atropine times, not responding. You have to do a VVI or a AV sequential. So, patients may have LCOS related to cardiac arrhythmias in the postoperative period. Hemodynamics compromise. Ventricular tachycardia, ventricular fibrillation, most dangerous. If they are hemodynamically significant, you should be fibrillating as the first thing. Start with 2 joules per kg, go to a maximum of 8 joules per kg. Check the potassium acidosis acutely and keep the potassium in range, as most of the children will be massaging. It does not go very high, it should not go very low. And acidosis, if it is there, this is corrected, because acidosis is something which will affect your pacing. In case you require to do VVI pacing later, it will. Okay. Adrenaline post-defib can be given, especially with a slow heart rate at 0.1 ml per kg of 100,000, and infusion can be started at 0.1 to 0.2. Amiodarone can be given in a situation as a 5 mg per kg bolus over 20 minutes at 5 mg per kg per 5 mics per kg. I'm sorry, the per minute is not required out there. 5 mics per kg. Over to the acute situation, the patient is having ventricular fibrillation, Cordron should go in minimum of 20 minutes. Please don't give it very fast, because then the heart will never come back. So it should go 20 minutes. So please see, when the nurse is sitting, time and again reiterate your order that it should be going over 20 minutes, so that its syringe pump is set accordingly. In the Keteron doesn't work, you can use lignocaine, you can use a small, and in the last stage ECMO, obviously. But if you do things properly, maybe the things should get better with defibrillation, a little bit of adrenaline, correction of acidosis, and making sure identify the cause, whether it was hypoxia or anything else. So we wrote the resuscitation tree, the entire diagram, which I'll show as the last thing. You have what the aggravating causes, H and T's. Those H and T's you have to look in most of the situations. Ectopic tachycardia, one of the most dangerous and resistant post-operative phenomena that we all see. Now, when it happens with junctional tachycardia, the checklist is correct volume status, control temperature, optimize calcium, magnesium, and potassium, overdrive atrial pace if the jet is at a lower rate. Okay, if hemodynamic deterioration significant, consider amiodarone. If hemodynamic sustained, can consider beta blockers, especially if a reasonable RVO to LVO gradient is there. Avoid tachycardia-inducing agents, which is dopamine, dobutamine, adrenaline at high doses. So don't eat dobutamine, preferably beyond 7.5. Keep adrenaline around 0.1, not more than that. Avoid dopamine. Keep the patient sedated, preferably using dexmedetomidine, which controls the heart rate and balance opioids intermittently. Now, essential tachycardia also is a form of SVT, but the SVT which is originating in the atrium. Here also you have to avoid inotropes with a prominent inotropic effect. Optic sedation, edudocin can be given, especially in the face of hemodynamic compromise for an SVT, and see if it responds. Do you know adenosine has to be given with a flush? So because the half-life is very small, 12 seconds, and hence you do not want to waste. So start at 0.1 milligram per kg. You can go to 0.2. Rapid atrial pacing is done at a higher 120% higher rate. Now, how do you do rapid atrial pacing? Now I'll just show it to you. Okay, so you have the atrial pacing, which is there set at something like around 80 to 84, 80, 90, for example. Now you can see in the lower panel there, this is atrial sensitivity. In the lower panel, there's rapid atrial pacing out here. Now, how I go there, I just scroll through. I press here, I go to rapid atrial pacing. Then I press out here. Okay, that's activated. Here, the rate of rapid atrial. Now, suppose the patient's SVT rate is around 2. Here, you may have to go to something. This is, see, this I'm adjusting the rate from here. This knob. You have to go to something like a 450, and you get the way the light is flickering when I press this. See this. When I press this for giving rapid atrial pacing. Okay. Then when you sometimes because of this, you can have a sort of a cardioversion happening. Okay. Because to reduce the refractory period of the for the atrial impulses. If hemodynamic significant range, synchronized cardioversion has to be given. If nothing is working, use a synchronized cardioversion at 1 to 2 joules per kg. The synchronized to the R wave on your ECG, and hence it's called synchronized cardioversion. Different from a defibrillation. Defibrillation is used for ventricular fibrillation or hemodynamically significant ventricular tachycardia. SVTs, you use cardioversion. Okay. Again, amiodarone 5 milligram per kg, sorry, which is as a bolus for 25 mg per kg per minute for 4 hours, and then 10 mg per kg per minute as an infusion. So can you use a bolus of 5 milligram per kg given over 1 hour or 20 minutes, depending on the acuity of situation, followed by 10 microgram per kg infusion, or you can give 25 mg per kg per minute for 4 hours and 10 mg as an infusion later. Beta blockers, basically, you have your prolol, which can be given at 0.1 milligram per kg. Digoxin in selected situations, 10 mg per kg per day. Flecainide, 1 to 2 milligram per kg a day, depending on the situation. But flecainide cannot be used with ventricular dysfunction. It can induce ventricular dysfunction. So you can go to 1 to 3 milligram per kg per day, but don't exceed 3 by any means. Okay. Rapid, which is, as I showed, overdrive pacing is something which we do out here, especially is very beneficial for reentrant. The myocardium in the reentrant limb is depolarized by an antegrade pacing spike before the reentrant depolarization of the preceding beat arrives. And as arrived, the myocardium is in a refractory state. As you induce a refractory period because of fast rate. And this way you block the reentrant pathway. Okay, that's it. Under drive pacing, which is at less than SVT rate, the pacing spike induces the refractory period in the reentrant loop. But now that is something which very rarely. So overdrive works in SVT and drive rarely works. Okay, that's just what you need to remember. It very rarely captures it in that acutely it may capture and it will just block the reentrant pathway if you're lucky. For the initial tachycardia also, overdrive pacing at 120% high rate can sometimes work. So you can try that. Okay, but always. AV junctional tachycardia, the primary checklist of volume, electrolytes, temperature, everything has to be sorted out much before you look at all these things. Okay. 1:1 conduction is achieved, the pacemaker rate is gradually reduced. Once the pacemaker rate falls below the endogenous rate, sinus rhythm can be achieved. It's not very commonly seen in children, but yeah, sometimes you do, especially in adolescents. And type 1 with rates of 320 to 340 per minute, you can use where basically set above the flutter rate and gradually increase until the atrial complexes changes morphology on surface ECG. Typically, this will be at a rate of 10 to 20 more than the flutter rate. The pace after that is then gradually reduced to a rate below the endogenous sinus. Okay, that's important. ventricular rate, induced rapid atrial fibrillation, which we just showed, and if it's sinus can be placed on backup rate below sinus. If not, and it remains a rapid atrial fibrillation, if it is AV block with ventricular rate slower than with SVT, may help. Okay, so if you atrial fibrillation into sinus by reducing a refractory period. If not, even in that case, if it reduces AV block with ventricular rate slower than SVT, you may garner some benefit. The ventricular rate control can happen. AV dissociation, if it happens acutely, will be hemodynamic significant. In a crisis in OT, you may use a DO because you have a cautery. At the night ICU, you use a DDD. Always reassess the drugs, for example, like the expectorubidine, which can precipitate a slow rate in AV dissociation. Check lights, rule out hypothyroidism, rule out hypothermia, correct metabolic acidosis. So acute sometimes lift in the temperature with hypothermia where the patient is still being shifted, coming off bypass, can sometimes lead to these problems. Hypothermia associated can lead to these problems. Okay. So the final arrhythmia checklist is around temperature, drugs, which can precipitate arrhythmia, volume, electrolytes, calcium, magnesium, potassium, metabolic hypoglycemia, and hypoxia. These are the factors which need to be the correctables, which we say should be corrected while we talk of the higher things of fibrillation and all this stuff. But we need to understand that primary things have to be looked at first, especially in any arrhythmia. Now, hypothermia can lead to AV dissociation, hypothermia can lead to SVT, hence temperature control. Drugs, for example, somebody is getting dobutamine at 10 to 15 mics, can have tachycardia because of that, so control that. Because it's a cardiac patient, somebody is very resistant to in a right-sided failure, you're not giving too much volume, and there's a preload deficiency, you may have a problem. That should be maintained as in homeostasis because you have a situation where you give diuretics and that can lead to hypomagnesemia. So you have to maintain the magnesium in range with 0.1 ml per kg of a 50% solution. Or if you have a 25%, you may go to 0.2 depending on the magnesium level. Calcium and potassium has to be obviously garnered in the normal range. Very important in the postoperative phase. We are giving out blood and all the stuff. And prevent hypoglycemia and prevent hypothermia. So this is the thing about the pediatric cardiac arrest and everything that we have. This is basically absent rhythm, hastily. What to do? They're all available. You all are aware about PALS. Just remember that these reversible causes, which are mentioned downstairs, they are applicable even to the pacing part of it. And quite a few factors if are there, especially acidosis, hypoglycemia, hypothermia, the pacing may not function. And hence it's relevant that reversible causes can lead to pacing failure that needs to be corrected. Okay. About pediatric tachycardia, which is you've already discussed how to go about it. Okay. About amiodarone and everything. Okay. This is the only condition where atropine still has got a role. Okay. So that's it for the day. The complex lecture. So I hope there are some questions. If you're not comfortable asking it just now, you can ask me on email. If you're comfortable